again. So we move forward, and it gives me immense pleasure to call upon our next speaker, Dr. Sarika Gupta, additional professor in the Department of Pediatrics, King George Medical University. She'll be talking on what's new in pediatric TB guidelines, a very pertinent and a very important topic. I welcome you, ma'am.
Thank you, Dr. Arpita. Am I audible and my screen visible?
Yes, ma'am.
So as you all know that tuberculosis is a topic that is very common and it is pertinent to all clinical or non-clinical branches. So today is the update on pediatric tuberculosis, and this talk is based on updated guidelines from IAP, NTEP, that is the National Tuberculosis Elimination Program, and the WHO guidelines. So my talk will be under following heading. So what is TB burden? What is the natural history of tuberculosis disease? How to diagnose? What is the diagnostic algorithm for pediatric pulmonary as well as extrapulmonary tuberculosis? How to treat and monitor response? Few lines about the latent tubercular bacterial infection and drug resistance tuberculosis. So burden of the TB. So basically in India, the childhood tuberculosis constitute 10 to 12% of the TB cases. Earlier, 4 years back, it used to happen 6 to 10%, but now this prevalence of pediatric tuberculosis has increased up to 12% of the cases. And this childhood tuberculosis indicate that the adult tuberculosis is poorly controlled, because pediatric tuberculosis happen how? By contact with the adult case. So when we are talking about NTB strategy, so roadmap to zero death due to TB have to pass through childhood tuberculosis. So now the natural history of tuberculosis disease in this slide. So when there is a source case of tuberculosis and a child come in contact with that source case, in 70%, there is no infection, no disease. In 30%, there is infection, depending upon increased microbiological vigilance and decreased host immunity. And out of these 30%, 90 to 95% will have persistent latent infection, which will develop later as late reactivation disease, as we do screening for tuberculosis in a child of nephrotic before starting steroid therapy, patient who is taking chemotherapy. Okay. So apart also, 90 to 95% is going to have latent infection. And so risk of infection to having primary disease is just 5 to 10% lifetime. But this risk increases to more than 50% in infants, and the risk is just 2.5% in children 1 to 5 years old. So basically, infants, that is less than 1 year, there is high risk of infection going to disease. So all the smear positive cases, they are definitely infectious. The smear negative, they can also be infectious because it may be possible that the bacilli was not detected by the smear examination. Extrapulmonary disease looks like non-infectious, but if they have a pulmonary focus, then again they can be infectious. So this was natural history of the tuberculosis. Now, how to diagnose childhood TB? So a case. So this is a 3-year-old child who presented with cough off and on for 2 months, which was dry more for last 3 days. There is low-grade fever for same duration, which was not documented. Mother said that the child was not growing well. He is basically fussy eater, predominantly milk-based diet. Father is smoker, had seasonal cough, and had received several sets of antibiotics with no relief. On examination, weight of this child was 10.7. Mild pallor was present. There was no lymphadenopathy. On chest examination, bilateral freckles and beads were there, and rest examination was within normal limit. PPD, it was for positive, 14 millimeter in transverse axis. ESR was 32. TB ELISA was positive for IgG&M, and X-ray chest was this. So can anyone text what are the criteria to start ATT in this patient? Please only those comment who had not seen this case earlier. Those with whom I had discussed this case earlier, please don't write. So can anyone? What are the indication in this case to start ATT? Okay, so no one want to take opportunity to start ATT? We do start ATT daily. Okay, so we will come to this case later on. So how to diagnose childhood tuberculosis? So Dr. Shalini has written nothing. Okay, very good. So first of all, clinical feature. So clinical feature, it should be suggestive of tuberculosis. What they are, I will discuss. Then positive family history of contact. So for diagnosis, go in this sequence only. Then look at the X-ray chest. Is the finding suggestive of tuberculosis? Tuberculin skin testing and molecular test, which are most important. So clinical feature. So fever for 2 weeks or more, which is persistent, and there is no another cause to explain that fever. Unremitting cough for 2 weeks or more. So cough, it should be unremitting. It should not be like in a simple viral URTI, it happens that cough is there for 2 weeks or more. But that time, but there it has an increasing intensity, then going on decreasing intensity. But here, for tuberculosis, it should be unremitting cough for 2 weeks or more. A documented loss of weight, which should be more than 5% of the highest weight recorded in the past 3 months. Any painless peripheral swelling, that is cervical lymphadenopathy or any other kind of lymphadenopathy. Meningitis of insidious onset, that is more than 7 to 10 days. Any gibbous, spinal prominence, or any non-specific symptom in a context of an infectious tuberculosis case. So that will also be a clinical feature suggestive of pediatric tuberculosis. So it is labeled as presumptive pediatric tuberculosis on the basis of these clinical features if they are present. Then history of contact and exposure. So what is a source case? A source case is usually a person with infectious tuberculosis, usually sputum smear or culture positive, who transmit infection to one or more other individual. And contact is a person who has been exposed to the source case in last 2 years. Now who are close contact? So a person who is not exactly in the household, it can be in household, but who share in close space such as social gathering place, workplace, or a facility with the index case for extended daytime period during the 3 months before the start of the current treatments 2 episode. Like it can be possible that your child is going to school with a cab driver and or your own car driver. Car is all the mirrors are up because AC need to be run, and that person is coughing. So that period will be a closed space, and that will be like that contact with the source case will be for extended period for the last 3 months. So apart from the family, we have to scrutinize all other person who share extended daytime period during the last 3 months before the start of the current treatment. So these are the close contacts. Now the chest radiology. So this hold very important place in diagnosis of tuberculosis because of the possibility nature of childhood tuberculosis. However, the clinician must learn a skill of reading the X-ray chest to improve TB diagnosis. So in this X-ray, so can anyone text what is here on X-ray chest? Nothing abnormal on X-ray chest? So hilar lymphadenopathy. Okay, good. So it looks like hilar lymphadenopathy. Definitely, everyone will feel like that only. But if you look at the dome of the diaphragm, so where it is coming? So it is coming on the. So it is just coming on the 4th rib. So basically, to comment upon the hilar lymphadenopathy or the X-ray chest should be in the inspiratory film. The inspiratory film is that the anteriorly either a dome of diaphragm is lying on the 6th rib or posteriorly the ribs are 9th. So posterior rib should be 9th where the dome of diaphragm is lying, or anteriorly the 6th rib. So this is the expiratory film. So because it is expiratory film, lung volume is reduced, so it is giving a pseudo prominence of the hilar area. So basically it is not hilar lymphadenopathy. So that's why skill must be learned to interpret X-ray chest. So what are the highly suggestive manifestation for this thing, X-ray chest regarding TB? So patterns like hilar lymphadenopathy, chronic fibrocavitary disease, which is very common in the children more than 10 years, that is in adolescent age group, and miliary pattern. And remember that this specificity increases in a child with tuberculosis specific symptoms and positive TST. And if it is so pattern like consolidation, non-homogeneous opacity, ground glassing, thin walled cavities, these are non-specific to tuberculosis. So if these are present, it doesn't suggest tuberculosis. And remember that in such situation, microbiology become an important place. And if negative, take a specialist opinion and consider other investigation like CT chest, bronchoscopy for evaluation of the persistent pneumonia. Because often we had found that a child who has been treated, a case of persistent pneumonia being treated as tuberculosis, finally diagnosis come up something different like congenital lobar emphysema or S-shaped fistula or tracheoesophageal fistula or CF or primary immunodeficiency. So we have to remember that specific and non-specific manifestation. So this is a good inspiratory film. So this is the right hilar point and this is the left hilar point. Left hilar is a little bit above than the right hilar point. And this convexity, which is originating from the hilar area on both sides, it is hilar lymphadenopathy. Then this pattern, anyone can tell it is miliary pattern. And this one is a fibrocavitary pneumonia. So the consolidation patch and in between that a thick walled cavity is there. So this is fibrocavitary pneumonia. Ultrasound chest, where does it hold place? So it is a useful test to localize pleural effusion, whether their internal echo septations are present or not, to differentiate whether the shadow is thymus or NTL lymph node, and to identify best place for aspiration, FNAC or biopsy in a peripheral region. CT chest, so basically it is not routinely recommended for the tuberculosis workup, but it is an important tool for workup of persistent pneumonia not fitting into a recognizable pattern. And it shows greater anatomical detail of mediastinal lymph node size, their characteristic, the hidden area like the apex, the base of the lung, the posterior area, and it gives better description of type of shadow, whether it is a consolidation or atelectasis or bronchitis. And on CT, the signs suggestive of tuberculosis include a cavity or a tree in bud pattern. This is most often associated with smear positive. And lymphadenopathy and collapse, they are often seen in smear negative, but this is not a one-by-one rule. Variation can be there. So for summary of radiological interpretation, so reading of radiology, it is an important step. So we have to remember TB suggestive and non-suggestive shadows on X-ray chest, and diagnosis of tuberculosis based on clinical symptom plus X-ray has to be called as clinically diagnosed tuberculosis. This we need to remember. And CT scan and ultrasound are contributory and recommended in selected situations only. Now coming to tuberculin skin testing. So what is that? It is intradermal injection of PPD. And it elicits delayed type hypersensitivity reaction, and it indicates present or past infection with mycobacterium tuberculosis, not the disease. This is the most important point. It suggests infection only, not the disease. But it is used in etching to other tests in the diagnosis of TB, like with X-ray, with clinical feature, with molecular test, and a positive tuberculin skin test defined as 10 millimeter or more in duration. But the optimal strength of tuberculin should be either 2 TU, that is the recommended, or 5 TU for diagnosis in children. And it is important to raise a wheel of 6 millimeter after intradermal injection. It has to be read after 48 to 72 hours of injection, and it is considered positive in duration is more than 5 millimeter in a HIV positive child. If a patient returns beyond 7 years, but by 7 days, a positive test can still be read. So a positive test suggests infection, not the disease, but we must also remember that negative test doesn't rule out TB infection, as in a child who is immunocompromised in that condition, or a child who is on steroid therapy in that condition, again, it can be negative. It doesn't help in guiding duration of treatment. It doesn't help in detecting or a reinfection or reactivation, and there is no role of BCG diagnostic test. So limitations, again to emphasize that BCG can, so specificity and positive predictive value limited in BCG and non-tubercular mycobacterial exposed person, but uncommonly the reaction will be more than 10 or 15 millimeters. And sensitivity and negative predictive value limited in HIV infected, recently exposed, young and malnourished. And Another important thing that we have to remember, that non-availability of standardized tuberculin in India is a cause of concern. So whenever you have to do tuberculin skin testing, do it from the NTP center only, not from any private pathology or other, because they are not, the private persons are not going to have the standardized tuberculin. So always do it from the NTP centers, which are there in your hospital or in your vicinity. So now the new test, that is CTB test. So it is a next generation skin test for detection of tuberculosis. And it is specific because it is based on a specific antigen of Mycobacterium tuberculosis, that is ESET6 and CFP10. It is unaffected by BCG vaccination status. And it is also given as Von-Tuch's test by intradermal injection. And in here, in duration of more than 5 millimeter indicate infection. And it is not yet available in country, but soon will be available. And why it is importance and why the future will be of CTB test, because tuberculin source lot is finished and equivalent lot may not be seen. So CTB or DAL skin tests are likely to replace in coming future. And in future, we can call it as TB skin test rather than tuberculin skin test. And IGRA may be an alternative in future. So what is IGRA? That is interferon gamma release assay. So it is in vitro stimulation of whole blood with Mycobacterium tuberculosis specific antigens like ESET6, CFP10 and TB 7.7. And two commercially available tests include quantiferon gold in tube test and ELISpot TB. So both IGRA and TST are basically done to detect latent tuberculosis infection. That is, they do not detect actual TB bacilli, but only the immune response that suggests past or present exposure to tubercular bacilli. And both IGRA and TST cannot distinguish between latent tubercular bacterial infection and active TB disease. This needs to be remembered. So a summary for IGRA TST is that they cannot accurately predict risk of infected individual developing active TB disease. They should not be used for diagnosis of active TB disease. IGRA is a little bit costly and technically complex. That's why it is not in the practice currently, or not guided, not recommended by the NTP program. And that's why in our country, where there is high TB and HIV burden, low middle income countries, no enough data is there to support replace TST by IGRA. Align on serology. So there is no role for inaccurate, inconsistent diagnosis like IgM, IgG, IgA antibodies against Mycobacterium tuberculosis antigen. Most important, microbiology. So basically in pediatric, which we all know is a paucibacillary disease. So we have two hurdles: that access to specimen. Most of the child are not able to expectorate sputum. And second hurdle is that there is low sensitivity of smear and moderate sensitivity of culture examination in children. So despite this hurdle, WHO and NTP do recommend that every effort should be made to demonstrate bacteriological evidence for the diagnosis of pediatric TB. Sample can be either sputum, if the child is able to expectorate, or we can use alternative specimen. Most often we use gastric lavage. Sometimes we can use induced sputum. And if bronchoscopy is possible, then bronchoalveolar lavage can also be used. So all efforts should be made depending upon the feasibility and the supervision of pediatrician to have a sample to demonstrate bacteriological evidence. So what are these tests? WHO approved rapid diagnostic tests. So most of when that is used, and that we all know, that is CBNAT. Earlier it was expert MTB-RIF, and now it is expert MTB-RIF Ultra. So what is the difference? So basically both are saying that they are going to detect Mycobacterium tuberculosis and rifampicin resistant. But for expert MTB-RIF, 118 colony forming unit were required, while for this Ultra only 16 colony forming unit is required. So sensitivity is very much increased. Another test is TrueNAAT, by which we can detect. It will come in a picture in future. Line probe assay, definitely it is done. TB lamp may also come in future. And liquid culture and drug susceptibility testing. And one of the liquid culture that is commonly used is a Mycobacterium growth indicator too. So these are the different microbiological tests available for the diagnosis of tuberculosis. And with the use of these molecular tests, that is PCR-based technology, it is preferable to use the term microbiologically positive TB rather than smear positive TB for pediatric tuberculosis. Line probe assay. So it is basically used on smear positive specimen or culture isolate for genotypic DST. That is like if we had done CBNAT on a patient, CBNAT is negative, but we are suspecting TB. So a lot of the sample that is kept, that is used for liquid culture followed by genotypic DST by line probe assay. So it is first and only WHO recommended test for detection of additional resistance to Mycobacterium tuberculosis resistant TB patient or XDR-TB. So it detects TB, it detects resistance to rifampicin and isoniazid, that is the first line LPA, which is known as MTP-DR+. Then second line LPA, which suggests resistance to class fluoroquinolin, and second line injectable, that is known as MTP-DR-SF. And it produces result in just 24 to 48 hours. So, but remember that if a CBNAT was negative, a liquid culture was done and then LPA, then total time taken can be 14 days to 42 days, क्योंकि पहले liquid culture process होगा, then उसके बाद LPA होगा. But LPA actual time is just 24 to 48. And it helps in decision about a regimen, that whether to give short or long drug, MDR or XDR regimen. So now role of culture. So definitely culture will show the bacteria. So diagnostic yield is going to definitely improve. And liquid culture has changed the scenario. Solid culture initially, which were used, they take a longer time. But liquid culture has decreased time. So Mycobacterium growth indicator tube is now available through NTP lab networks and other accredited laboratories. And under current universal DST strategy, it may be used upfront with a specimen like induced sputum, gastric aspirator BAL if molecular test, that is CBNAT, is negative. And it produces result faster than conventional LG media in just 14 days. So national strategy about universal drug sensitivity testing by culture or other molecular method for all TB cases is this, that what is the order of preference? Sorry for mistake here, RNTCP, it is NTP approved nucleic acid amplification test based on turnaround time. So first choice is do CBNAT, Gene Expert, Ultra, which take just 2 hours, followed by molecular DST using line probe assay if smear was positive. Second choice, liquid culture MGIT, followed by line probe assay drug sensitivity testing, which take 14. And third choice can be liquid culture MGIT, followed by liquid drug susceptibility testing, which take 42 days. So these are the order of preference. So we all do first CBNAT and then we go for first line and second line LPA and liquid culture. So summary of molecular test is that new diagnostic algorithm incorporate uses of newer technology like CBNAT, which is more sensitive than smear or microscopic examination. And yield to effort for CBNAT is maximal if the chest radiology shows suggestive lesion. So all cases suspected to have TB with smear negative result, and in all other situations, CBNAT shall be preferred to smear examination, provided the X-ray is also showing some pathology suggestive of TB. And always remember that retain one aliquot of the specimen for liquid culture if the CBNAT is negative for Mycobacterium tuberculosis. So basically, microbiology people do keep a lot of sample to do further first line LPA. So while nucleic acid amplification tests higher sensitivity than the smear, yet it fails in many possibacillary cases. So it is good only as a rule in test, and negative NAAT doesn't rule out TB, but definitely we have to rule out other causes of persistent pneumonia, that we all have to remember. So the case which was earlier discussed. So again, if we look at the clinical picture, so he had cough off and on for 2 months. It was not persistent. It was not unlimited. Fever was not documented, low grade for the same duration. And not growing well. So basically, आप किसी की भी mother से पूछ लो, उनका बच्चा कभी भी properly नहीं grow करता है. So there was no objective evidence of weight loss or static weight. Fussy eater, most of the child are like that only. Father do have cough, but he was a smoker, so it may be like chronic bronchitis. And X-ray chest, it was already discussed that it was expiratory film, so we can't comment on hilar lymphadenopathy. On examination, so nothing like that. TST, it was although positive, but the strength that was used for 10 TU. So now it is recommended to use just 2 or 5 TU. ESR has no role. TB ELISA, WHO has given negative recommendation for doing ELISA. So there was no basis for starting ATT in this index chart. And there was no attempt at any microbiological diagnosis. So what are the diagnostic algorithm for pulmonary tuberculosis? So a presumptive pediatric tuberculosis patient, first we have to do X-ray. If X-ray is highly suggestive, then do the effort for microbiological diagnosis, expector sputum, gastric aspirate, induced sputum for CBNAT. If CBNAT positive, it is microbiological confirmed TB. If CBNAT negative, but skin test is positive, and you are very sure that there is no likely alternative diagnosis, it will be labeled as clinically diagnosed TB case, right? If CBNAT is negative plus skin test is also negative, then first look for an alternative cause for this persistent X-ray shadow. Second setting can be the X-ray is having non-specific shadow, skin test is positive. So first give a course of antibiotic for 7 days. And even after that, within for the next 14 days, 1 month, if there are persistent shadows and symptoms, then again do attempt for a microbiological diagnosis. If you are able to found a sample and it comes positive, then it will be labeled as microbiologically confirmed TB case. If CBNAT is negative and skin test is positive, so again look for alternative diagnosis. No diagnosis alternative, label it as clinically diagnosed TB case and start treatment. If X-ray non-specific shadow, CBNAT negative, skin test negative, then definitely refer to expert for workup of persistent pneumonia. If X-ray is normal, but skin test is positive, then first evaluate for extrapulmonary tuberculosis. If X-ray is normal, skin test is also negative, then definitely you have to look for another alternative cause for these kind of presentation. So this is the algorithm for pediatric pulmonary tuberculosis. Same is for the extrapulmonary tuberculosis, that first we will try to have an appropriate specimen from site. If it is available, CBNAT detected, rifampicin sensitive, so it will be labeled as microbiologically confirmed extrapulmonary tuberculosis. Rifampicin indeterminate, then repeat CBNAT on first fresh specimen, indeterminate again on second specimen, so collect sample for liquid culture. Rifampicin resistant, then you have to start management of drug resistance tuberculosis. If MTB is not detected, so in that condition, if there is high clinical suspicion, then follow this flow diagram. So sample not available, you are having a high clinical suspicion, you had used another diagnostic tool to rule out other alternative causes, and then you will label it as clinically diagnosed TB. And if some other diagnosis has been confirmed, then start treatment for alternative diagnosis. So one case more. So this is a 13-year-old boy who presented with fever for 4 weeks, which was daily and documented up to 101 degrees Fahrenheit. Cough for the same duration, which was daily, persisting with a sputum, no hemoptysis. And there was weight loss in past week, which was documented. Previously it was 50 kg and current weight is 45 kg. So is he likely to have TB? And what is the next step? So what will you do on the next step? Can anyone text? So is it looking like TB? And what will you do on the next step? So very good. We will first do the X-ray chest. Because as per the algorithm, a patient, presumptive tuberculosis patient, first we have to do X-ray chest. So we did that. So this was the X-ray of the patient, and we do TST also with 5TU or T2U, which was available. And remember that this algorithm is only for the children who have no risk factor for drug resistance. So is the X-ray suggestive of TB? What findings are there on X-ray which suggest that it can be TB? So I had told 3 patterns which are specific for tuberculosis. So which pattern is visible here? Is it hilar lymphadenopathy? Is it
Please answer in the chat box.
Or it is fibrocavitary? इतनी सारी hints दे रही. Okay. So there is definitely a cavitation with surrounding consolidation, and it is thick wall. Remember that thin wall cavities are not specific for TB. There are other area of consolidation, and there are nodular inhomogeneous opacities on left side. So X-ray is suggested for TB. So what will you do next? आपने X-ray करा लिया, आपने skin test करा लिया. So what next? As per algorithm, अभी next क्या करेंगे? Yes, very good. So we will go for a molecular test. So we do sputum, since this child was able to expectorate, so sputum was MTB negative on CB NAAT. So what? Clinical picture, X-ray and PPD were suggested. So it will be labeled as a clinically diagnosed pulmonary tuberculosis. So our child fall in this category, that X-ray was highly suggestive in presence of presumptive pediatric tuberculosis symptoms. CB NAAT was negative, skin test was positive, and there was no other likely alternative diagnosis that we had worked off. So it was labeled as clinically diagnosed TB case. So now treatment, few lines. So treatment has three goals. There should be a relapse-free course. There should be prevention of drug resistance, and we have to break chain of transmission by rendering the patient non-infectious and decreasing the pool of infection. So how that? So इसमें कुछ गड़बड़ लग रहा है इस category में. So basically अब category 2 withdraw हो गई. There is nothing like category 2. There is only one category. So you can say, so new microbiologically confirmed pulmonary tuberculosis, new clinically diagnosed tuberculosis, either pulmonary or extrapulmonary tuberculosis, new microbiologically confirmed extrapulmonary tuberculosis, and previously treated TB, either recurrent, failure, treatment after deferred. We have to start on 4 drugs for 2 months, followed by 3 drugs for 4 months. So this is the NTEP protocol. WHO said that in continuation phase, we can give just 2 drugs. For this category, that is the previously treated TB patient, although we start this treatment, we do the drug resistance TB algorithm by drug sensitivity testing. So we do attempt to have the evidence of the resistant pattern, but first we start this one only. Dose we must all remember. So although it is vague, but कि सबको याद रहे, इसलिए मैं एक ही फिगर बता रही हूँ. So isoniazid 10 mg per kg, इतना तो देना ही देना है. Rifampicin 15 mg per kg, pyrazinamide 35 mg per kg, ethambutol 20, and streptomycin 20 mg per kg. So this is the dose of the different anti-tubercular drugs. However, streptomycin is being here. Now it is not in the first category. So treatment duration, it was for 6 months, but for TB, meningitis, spinal TB, miliary disseminated TB, and osteoarticular TB, the continuation phase can be extended to make a duration of total treatment to 10 months or 12 months on a case-to-case basis in case of delayed response, and all as per the description of the treating physician or pediatrician. So now in the program, the fixed drug combination with appropriate dosing is available. So 3-drug FDCP is available, which is labeled as P, and 4-drug FDC, which is labeled as A. So that are being available in program, and they are given as per the different weight band. So the program person have this weight band, and they provide tablets according to the weight band. Most important, how to write TB prescription. We often write that pulmonary cough or just TB. So what are the essential components of prescription? First, we have to write about diagnosis. So just writing TB or coughs not acceptable. Detail needed, like what is the basis of diagnosis, clinical feature, history of contact, X-ray, PPD, molecular test. Then type of patient, is a new patient or it is a relapsed patient, what is the past history of patient, type of disease, pulmonary or extrapulmonary TB. Extrapulmonary can be tubercular lymphadenitis, it can be abdominal tuberculosis, it can be TB. Then what is your treatment plans? Is it like category 1 treatment, or you are planning for testing for drug resistance and then upgrading the treatment? And most important, notification of case through NICSHA ID. And apart from that, some other treatment support like nutrition, like pyridoxine, like that. So adjuvant treatment, most important is steroids. So what are the indication to use steroids? So it is used in tuberculosis is pericarditis, massive or bilateral pleural effusion, and other indication include miliary tuberculosis with alveolar capillary block, spinal cord compression with neurological deficit, endobronchial obstructive lesion, peritoneal TB, adrenal TB, vasculitis, or aortoarteritis. So these three are definitely we have to give the steroid. And dose is 2 mg per kg prednisolone daily or Dexa 0.6 mg per kg per day for 4 weeks. And after that, dose is tapered over next 4 weeks before stopping. Pyridoxine supplementation is given 10 mg per day because isoniazid causes peripheral neuropathy, which is most of the time clinically not detected. So pyridoxine we have to give by the dose of 10 mg per day. And definitely nutritional support we have to give as a pediatrician, ensure breastfeeding, ensure appropriate nutrient intake, calorie and protein intake. Then monitoring, how to monitor the treatment. So when to assess, आपका follow-up के लिए बुलाओगे. So at 15th day, then 30 days after start of therapy, then every 1 month till completion of the treatment. And when you will call, what you will assess? You will assess for appropriate therapy. Child is taking in appropriate dose or not, then response to therapy. So clinical or symptomatic improvement is to be assessed at the end of the intensive phase and at the end of the whole treatment. Also look for other comorbid condition, HIV, severe acute malnutrition. Radiological changes may persist and may not correlate with clinical improvement, hence should not cause concern. A child who can expectorate, follow-up sputum examination has to be performed with the same frequency as an adult, that is at the end of intensive phase and at the end of the total treatment completion. CBNAT is not appropriate for follow-up for monitoring the progress of disease. Can anyone text why CBNAT not? अभी तो इतना बताया कि CBNAT बहुत जरूरी है टीबी की डायग्नोसिस के लिए, पर follow-up में CBNAT नहीं करा रहे. Why not? Anyone? Can anyone guess why CBNAT is not recommended for follow-up? Poor sensitivity. Actually, CBNAT is what? It is a molecular test. ये DNA detect करेगा. तो अगर वो dead bacteria भी पड़ा है, उसका DNA भी वो detect कर लेगा. So that's why CBNAT is not done. But sputum examination, जहाँ पे smear examination, जहाँ पे कि आप bacteria सीधे-सीधे देख रहे हो, that whole place for follow-up, not the CBNAT, because CBNAT can detect dead bacteria also. Long-term follow-up is also necessary. So after completion of treatment, the patient should be followed up clinically at the end of 6 months, 12 months, 18 and 24 months for detecting any recurrence of TB by looking at the presence of any clinical symptom again to be suggestive of tuberculosis. So this is also important that after completion of treatment, we have to follow up 6 monthly for 2 years. Latent tuberculosis, 1-2 slide. So latent tuberculosis, it is basically a persistent immunological response to TB, but not the active disease. So where we give treatment for latent tuberculosis, so a child under 5 years of age who are just 2 or 3 slides are left. So children under 5 years of age who are household contact of microbiologically confirmed pulmonary tuberculosis after ruling of active tuberculosis. A child born to mother diagnosed to have TB in pregnancy should receive prophylaxis for 6 months, provided congenital tuberculosis has been ruled out, and BCG must be given at birth or at the end of the prophylaxis. All HIV infected children who either had exposure to infectious tuberculosis case or they are positive TST more than 5 mm but no active disease. All TST positive patients who are receiving immunosuppressive therapy like nephrotic 1 on steroid, leukemia 1 on chemotherapy. Apart from this, other indication which had been added, so children and adolescents 5 to 15 years of age who are household contact of microbiologically confirmed pulmonary tuberculosis should be systematically tested for latent tuberculosis infection. If found by to have latent tubercular bacterial infection by PPD or IGRA, they should be offered prophylaxis. Children and adolescents 12 months to 15 years of age living with HIV positive patient after ruling out active tuberculosis. In all these conditions, chemoprophylaxis need to be given. So we all know that INH 10 mg per kg for 6 months, it is being recommended. But now the updated WHO guideline is saying that INH plus rifampicin daily for 3 months need to be given. And the upcoming, in the coming future, there will be combination of isoniazid plus rifampicin being advised for chemoprophylaxis in latent tuberculous bacterial infection, where isoniazid given daily for 6 months and rifampicin weekly. It is not available currently. Hepatotoxicity. So asymptomatic elevation of liver enzyme up to 5 times of normal is considered normal in a patient who is taking ATT. And if patient develop any signs of hepatitis, stop ATT immediately. Drugs are withheld till bilirubin reaches normal and liver enzyme start touching normal. And then drugs are introduced sequentially. First rifampicin, then isoniazid, and then pyrazinamide. Every 5 to 7 days by checking the level of enzyme as well as the bilirubin. But remember that if period without drug is likely to be prolonged and patient is sick and require treatment, then add at least 2 other drugs, streptomycin, ethambutol, or fluoroquinolone till offending drug can be resumed. Just 2 slides on drug resistance tuberculosis. So this is 2021 data, which suggests that about 1/4 of all TB patients are showing evidence of drug resistance. So what are presumptive MDR patient in children? So like non or poor responder to first line therapy, treatment after loss to follow-up, a recurrent TB case, or a contact of MDR-TB patient, or with HIV, or with history of tuberculosis death in the household. So all these are labeled as presumptive MDR, and they are then offered drug sensitivity testing. So in a presumptive drug resistance TB patient, if there is no bacteriological confirmation, bacteriologically negative, clinically diagnosed, probable is labeled as bacteriologically negative, clinically diagnosed probable drug resistance TB, and definitely after ruling out alternative diagnosis. So basic principles of treatment of drug resistance TB is always treat in consultation with the drug resistance TB expert, include at least 4 to 5 effective medicine from group A and B, to which the bacteria is most likely to be susceptible. Do not add a single drug to a failing regimen to avoid amplification of resistance. And strict monitoring is required. I am skipping this one. This one also because of the time constraint. So to summarize, so management of TB in children. So now the drug sensitivity directed therapy is the cornerstone. All efforts should be made to look for drug sensitivity. NTEP approved rapid nucleic acid amplification test has become the core investigative modality. Clinical radiological approach of diagnosis is used only when NAAT fails in a clinically probable case. But in all such clinically probable cases, do remember that you had excluded other alternative cause for persistent pneumonia or other extrapulmonary tuberculosis like of presentation. So thank you. So basically, don't be just inspired by this presentation, because habit is more dependable, because habit will sustain you whatever you inspired or whether you are inspired or not. So be persistent in your habit of diagnosing TB probably perfectly by clinical picture, TB skin testing, contact history, X-ray, and molecular studies. So thank you all, and if there is any question, I will answer.
That was an excellent presentation, ma'am. Thank you so much for updating our knowledge on recent changes in pediatric TB guideline. There is one question, ma'am. Do we need to send specimen for MGIT along with CBNAT in the first place, as a negative CBNAT can't rule out a disease?
Okay. So Dr. Shatakshi, so basically whenever we do send a sample, so whenever we send a sample for the CBNAT, so it is the responsibility of the microbiology department to keep a lot of that sample in store. So if it is like that CBNAT has come positive, rifampicin has been detected, then they will do the first line LPA. And if it is negative, then they will do on that sample culture to grow the bacteria and then do the LPA. So it is not our responsibility, because it is not possible every time to keep gastric aspirate collection is also not a very simple process. So microbiology, or we should emphasize them that, okay, we are sending this sample for CBNAT. Do keep a sample in store, that if the rifampicin has not been detected, then process this sample by liquid culture to grow the bacteria and to do the LPA. So am I clear?
Yes, ma'am. Ma'am, there's another question. When can we start ATT for a neonate who's pulmonary TB positive?
Can we start ATT for a neonate who is pulmonary TB positive? So Shivoy, from your question, as I am able to understand, that you are asking that if it is a congenital tuberculosis, or if okay. So a newborn who has been born to a mother who is TB positive, or so first, definitely you have to rule out any evidence of congenital tuberculosis. If that is there, then you have to start the treatment for the tuberculosis. If there is no evidence, then you will give this newborn prophylaxis for 6 months. Along with that, continued breastfeeding, along with BCG being given either at the birth or at the follow-up after 6 months. Okay.
Thank you so much, ma'am. I think there are no other questions in the chat
Thank
box.
you, Dr. Arpita.
Thank you so much, ma'am. So moving on, I am so happy to call upon our next speaker, Dr. Kanksha